I welcome you to the sixth lecture of this NPTEL MOOC course titled Psychology of Stress, Health and Well-being. So, this is the third lecture of module 2. So, today we will talk about the stress and psychological disorders. So, before we talk about today's lecture, let us have a brief recap of the last lecture. So, in the last two lectures, we are talking about how stress is connected to health, and in that context, we are talking about physical health, and we have discussed in the lecture 4 how stress is connected to non-infectious diseases, and in the last lecture, we have discussed how stress is connected to infectious diseases. So, we have discussed primarily that stress can influence infectious diseases primarily by affecting our immune system. So, in that context, we have discussed there is a whole branch of study called psychoneuroimmunology, which studies this relationship between psychological factors, neurological factors and immune system. And most of this connection between mental factors and immune system is kind of studied under this branch of study. Now, we have discussed in the under immune system, we have discussed that immune system is primarily governed by lymphocytes of WBC or white blood cells, and it includes primarily B cells and T cells. And most of the research shows that stress can influence our immune system, and some of the recent meta-analysis showed that that it also depends on what is the nature of stress. So, it was found that acute stress can enhance temporarily our immune system by mobilizing our resources, or at least redistributing the immune cells in the body. However, chronic stress is the main culprit in terms of affecting our immune system, and it deteriorates or suppresses all the immune functions. Then we have discussed the mechanisms between stress and immune system, and primarily we have discussed there are two mechanisms. One is the release of stress hormones, particularly the cortisol, which is released under chronic stress, suppresses the diverse immune functions, or immune cells are suppressed, or their function or either they are suppressed or they are not produced enough. Then the other mechanisms that we have discussed is behavioral pathways, which was associated with basically some of the behavioral changes that are associated with stress include excessive drinking of alcohol, lack of exercise, sleep difficulties, and all this can have further detrimental effect on our immune system. We have also discussed the implications of this research finding, primarily in the context of understanding that if stress can suppress our immune system, then the interventions aimed at reducing stress, such as relaxation or psychotherapies for enhancing mental and emotional well-being, all these should enhance our immune functions. And many research actually indicates this is true, in the sense that very recent meta-analysis of 56 studies involving intervention studies clearly showed that psychotherapies such as cognitive behavior therapies are associated with enhanced immune functions, and these are long lasting, that it lasted or it persisted 6 months after the intervention. So, therefore, the various stress management techniques can enhance our immune function apart from facilitating mental and emotional health. So, these are some of the important concepts that we have discussed in the last lecture. Today we will specifically talk about how stress is connected to psychological disorders, or how it impacts our mental health specifically. So, stress itself is not a illness or psychiatric diagnosis, but it can influence our mental health, and it can contribute to mental disorders. So, in this lecture we will discuss some of the key concepts, such as the relationship between stress and psychological disorders. we'll discuss in that context acute stress disorders, we'll discuss PTSD or post traumatic stress disorder, and we'll also discuss complex PTSD. So, these are all connected to stressful experiences in our life. So, the various research shows that stress can contribute to the development of various psychological disorders, such as depression, schizophrenia, anxiety disorders, eating disorders, post traumatic stress disorders. So, it can contribute to diverse mental health illnesses and disorders. So, since by itself it is not a disorder, but it can always contribute to all these disorders. We will so basically how it basically we have already seen that stress can very strongly influence how we think and feel, and this disturbances in the thinking and feeling can further contribute to various psychological disorders, which may be manifested in terms of our thought processes and emotional issues. So, we will not be able to talk about all the psychological disorders that are connected to stressful experiences, because it is beyond the scope of this lecture. We will specifically talk about two disorders. One is called as acute stress disorder and another is called as PTSD or post traumatic stress disorders. Now, in this context we should understand one difference between the conceptual difference between the term stress and traumatic stress. When we talk about stress, it could be a very normal day to day experience also. For example, you are stuck in traffic jam, it could be a stressful experiences. But when we talk about trauma, it is very specifically, it means very high intensity stressful experiences, which can be life threatening, which overwhelms your capacity to cope. So, it kinds of makes you helpless, and intense fear, horror, all these experiences are associated with traumatic stressful events. So, whenever we experience a traumatic event such as death of someone, loved one, or accidents. So, these are not just stressful experiences, these are highly traumatic experiences, which can overwhelm our capacity to deal with it. So, we may not know what to do with it, we can just go numb for some time, and mostly people experience intense fear, helplessness and horror when they encounter traumatic events. So, we should understand this the basic difference between when we say just stressful experiences and traumatic stress or traumatic events. So, let us start with the acute stress disorder. So, this is obviously connected to the stressful encounter and particularly traumatic events. So, and encounter to a traumatic event can lead to acute stress disorder. Now, in acute stress disorder is an intense, unpleasant and dysfunctional reaction beginning just after an overwhelming traumatic event, which can last, generally it lasts less than 1 month. However, if symptom persist for more than 1 month, it can be diagnosed as post traumatic stress disorder, which we will talk just after this. So, whenever we experience a traumatic event which are very overwhelming, unpleasant, then the general reaction that we or symptoms that we experience as a result of encounter to a traumatic event can lead to can be diagnosed as acute stress disorder if it persists for relatively longer time, but it is generally diagnosed as acute stress disorder if it is kind of symptoms are shown within 1 month. If it is more than 1 month, then it is generally diagnosed as PTSD. So, according to the American Institute of Stress, between 5 to 20% of people exposed to trauma such as car accidents, assaults, or witnessing a mass shooting, generally they develop acute stress disorder. And approximately half of such people, they develop PTSD. That means their symptoms persist more than 1 month. Now, acute stress disorder was a kind reclassified as trauma and stress related disorders in diagnostic. DSM basically means a diagnostic and statistical manual of mental disorders, which is basically maintained and and the evolution is primarily done by American Psychiatric Association. So, DSM 5 is the most recent one, which was introduced in 2013, and earlier this acute stress disorder and PTSD disorders were categorized under anxiety disorders. However, in DSM 5 they are categorized separately under trauma and stress related disorders category. So, acute stress disorder is generally kind of psychiatric diagnosis that may occur in patients after witnessing traumatic events such as or hearing about it or directly exposed to a traumatic event. So, it could be motor vehicle accidents, acts of violence, work related injuries, natural or man made disasters, sudden or unexpected bad news, etc. Symptoms of acute stress disorder generally includes anxiety symptoms, intense fear or helplessness, re-experiencing of the event, avoidance of the trauma related stimuli, dissociative symptoms. So, all these symptoms we will discuss in more much more detail in PTSD, which we will be discussing just after this. But one particular symptom category called as dissociative symptoms are more pronounced under acute stress disorder. So, dissociative symptoms primarily include kind of experiencing discontinuity or disconnection between your thoughts, memories, your surrounding environments, your actions and identity. So, it could be you may feel like you are fragmented, not a whole. You may feel detached, there may be reduced awareness of the environment, you may forget many aspects of your traumatic events, which is a kind of natural mechanisms by which our mind tries to forget certain important aspect of traumatic events, so that you do not have to remember it. So, it could be an unconscious mechanism. So, all these symptoms are there, and we will try to understand more detail about these symptoms in PTSD, because these symptoms are also very common in PTSD also. So, whenever we experience a stressful encounter, these are very common symptoms that particularly traumatic events, these symptoms are very common, and people may develop acute stress disorder if they persist, let us say for a month or 28 days, and if it is resolved, then it is kinds of ends with acute stress disorder, and if it is not resolved, one may be diagnosed as post traumatic stress disorder. So, persons with acute stress disorder are at increased risk for developing PTSD, because basically most the people with ASD actually develops, many of them develops PTSD. Symptoms generally must be persistent, present for minimum of 2 days, but not longer than 4 weeks or 28 days. Patients with persistent symptoms may develop PTSD. Symptoms of acute stress disorder typically peak in the days or weeks after the exposure to trauma, which is very natural. When we experience trauma, after the experience or encounter of the traumatic event, generally our symptoms peaks, particularly in terms of our anxiety symptoms, re-experiencing symptoms, dissociative symptoms, and then slowly they gradually decrease over time, and if it is resolved within 1 month, then you are just done with ASD. Now, we will talk about PTSD. Many of you might have heard about PTSD because it is quite discussed in medias and other in the popular media. So, it is called as post traumatic stress disorder. So, after traumatic event, if you develop a disorder, and particularly it is more long term persistent disorder, ASD is more short term reaction, PTSD is more long term reaction. So, PTSD is a kind of mental disorder that may occur among people after experiencing or witnessing extremely stressful or traumatic events such as war, disasters, accidents, rape, etc. PTSD has a very long history, and it has been named with many other names, and finally it became PTSD or post traumatic stress disorder. So, the whole diagnosis of or the concept of PTSD evolved out of war history or combat history. It has many almost all big wars or world wars were associated with the discussion or the understanding of the PTSD, and it evolved out of all the war veterans. So, let me briefly give you some of the historical perspective how PTSD evolved. So, during World War I, the PTSD symptoms were actually shown by many soldiers when they returned after the war or during the war. At that time it was known as shell shock symptoms, primarily because these symptoms were seen as a reaction to repeated exposure to explosion of artillery shocks. So, as a reaction to shocking experience of artillery shells, people were, it was understood that they were experiencing certain disturbances in their mind. Many also called it as a war neurosis. At that time there was not much understanding about this and many people were not even considering it as a disorder or problem, and even many people considered it as a kind of sign of weakness, that many soldiers are not mentally strong enough. So, that is why they are kind of shocked by war situations, and it was kind of seen as a symptoms of mental weakness also. So, many people also look at it like that also. So, there was not much understanding at that time, and it was kind of seen as a reaction to artillery shocks to artillery explosions and those kind of things. During World War II, this shell shock was kind of renamed or replaced by combat stress reaction, another term was used. Also people called it as a battle fatigue. So, World War II also not much development has happened during the World War II also, and at that time treatment mostly included giving them rest, people who are showing those symptoms of mental disturbances or soldiers who are showing the symptoms of disturbances, they were given rest so that they could recover and they can come back to the war again. And they were given some psychosocial support system, particularly the support was given from their soldier units and other things. So, mostly these type of things were done during World War II. In 1952, American Psychiatric Association first introduced its DSM or Diagnostic and Statistical Manual of Mental Disorder. So, the kind of manual for mental disorder was first introduced, that the first version DSM 1 in 1952, where they did not include exact PTSD kind of category, but they included something called as gross stress reaction, which was proposed only proposed for people who are relatively normal, but when they experience traumatic event, certain symptoms they were showing, but it was kind of seen as automatically people will recover within few days. So, it was not typically seen as a kind of disorder. However, this diagnosis was removed in DSM 2, which was introduced in 1968, and they included something called as adjustment reaction to adult life, again which was not exactly PTSD kind of category. it was not much helpful in terms of understanding this reaction of war veterans. It was in 1980 when American Psychiatric Association formally introduced PTSD or post traumatic stress disorder in their DSM-3 or the third revision of DSM, and it was introduced after a kind of result of many movements which included war veteran movements, particularly after Vietnam War. Many veterans were showing symptoms of PTSD. So, there was a kind of pressure and movement from the veteran side. There were many feminist movement, especially related to many sexual assault survivors were also showing similar symptoms. Holocaust survivor advocacy group was also involved in it. So, because this symptom was shown by many Holocaust survivors also. So, it was not just it was seen from the research that it was not just war veterans, but many other civilians are also showing similar symptoms after traumatic events. So, because of all these outcomes of movement and the research finding from all these people, it was finally introduced in 1980 in the DSM-3, and this diagnosis evolved after that. Then many revisions were done. DSM-3, then DSM-4, there was a revision in the PTSD diagnosis criteria, and then finally the most latest one is DSM-5, where it was also some revisions was done in terms of understanding the diagnosis criteria. So, based on the evolving research, few things were changed in every revision. So, serious attention to PTSD was given after the end of Vietnam War in 1975, which resulted in return of many psychologically disturbed US military veterans. Some studies suggested that about 500,000 of Vietnam veterans were suffering from PTSD even after decades of end of the war. So, it was really very horrific situation for veterans. So, this kind of became a major source for becoming or making it a formal diagnosis in the DSM. So, then obviously, it was introduced in 1980 in the DSM-3 by American Psychiatric Association. So, what are the criteria? So, we will see the most latest DSM-5 criteria, how a person is diagnosed with PTSD. So, there are many criteria. So, we will just discuss some of the broad criteria that are introduced in DSM-5. So, one thing in DSM-5, they have a separate category called trauma and stress related disorder. Earlier DSM-4, they were under anxiety disorders. So, PTSD first criteria is called criteria A, which says a person was exposed to death, threatened death, actual or threatened serious injury, or actual or threatened sexual violence in following ways. At least one of the ways is required to be diagnosed as with PTSD. So, there has to be direct exposure, there can be a direct exposure, or the person can witness a traumatic event happening in front of him or her, or learning that a relative or a close friend was exposed to a trauma. Even learning about traumatic event from another person can also lead to PTSD, or indirect exposure to aversive details of the trauma. In indirect exposure usually in the course of professional duties, for example, by first line workers or medics, when they are indirectly exposed to such aversive details of a traumatic event, such as for example, dealing with accident victims or trauma victims. So, at least one of these ways of exposure is required to be diagnosed with PTSD. So, this is criterion A. Criterion B says that traumatic event is persistently re-experienced. So, what happens in PTSD? One of the major symptom is that re-experiencing of the symptom. So, you persistently re-experience the traumatic event that has happened. So, let us say after accident, it is not going out of your mind. So, continuously you are re-experiencing this traumatic event again and again in terms of or in the form of unwanted upsetting memories. So, memories are coming back again and again, or you might be having nightmares about those traumatic events. You might have flashbacks about those traumatic events, emotional distress after exposure to traumatic reminders, physical reactivity after exposure to traumatic reminders. So, all these re-experiencing symptoms, at least one of the ways is there for patients with PTSD symptoms. So, people, it is kinds of unconsciously automatically comes back to their mind again and again. Criterion C says avoidance of trauma related stimuli after the trauma in the following ways, at least one is required. Trauma related thoughts or feelings, you try to avoid it. Trauma related reminders, you try to avoid it. Now, here is one important thing to kind of understand is that in the one hand the person is trying to avoid it consciously or unconsciously, any reminder that comes to the mind or any stimuli from the environment associated with those traumatic event. And on the other hand, there is a constant re-experiencing. So, person is automatically re-experiencing those symptoms. So, what happens? This is a kind of vicious circle. The more you try to avoid something, especially at the mental level, the more it comes to your mind. So, this is a kind of paradoxical thing. So, this is called as thought suppression in psychology, and many research shows that the more you try to suppress your thought, the more actually it comes to your mind. For example, in most of the thought suppression experiments, the participants are generally asked to suppress a thought. For example, they will be asked, you can remember anything or you can think about anything, but don't think about pink elephant for the next 1 minute. So, this is, let us say, suggestion is given to you. So, for the next 1 minute you can think anything, but don't think about pink elephants. And it was found very interestingly, all the participants were ending up only thinking about pink elephant, which was actually asked them to avoid. So, why it is happening is primarily because if you want to avoid something, first you need to remember it. So, automatically it comes to your mind. So, that is the problem. So, this is a similar kind of thing is happening with the PTSD people. They are trying to avoid thoughts and memories of trauma related events, but more they try to avoid, more kind of they re-experience it again and again. Criterion D includes the negative thoughts or feelings that began or worsened after the trauma. So, this was introduced in the DSM-5. Earlier this criteria was not there. So, this is a new introduction in the DSM-5. Negative thoughts or cognitions or feelings that actually starts after a traumatic event, or it is worsened by the traumatic event in terms of inability to recall key features of the trauma, overly negative thoughts and assumptions about oneself or the world. So, lot of negative thoughts about your own self and about the world in general. There can be exaggerated self blame or others for causing the trauma, heightened negative emotions, decreased interest in activities, feeling isolated, difficulty in experiencing positive emotions. So, at least 2 of these symptoms are required for the diagnosis of PTSD. The criterion E says trauma related arousal or reactivity that began or worsened after the trauma. So, hyperarousal, physiological reactivity increases, you become highly aroused in terms of physiological reactivity. So, you become highly irritated or become aggressive. One may tend to do more risky and destructive behavior. There is a hyper vigilance, small things can disturb you, small sounds from the environment can disturb you. There can be heightened startle reactions, difficulty in concentration, because of physiological reactivity. Whenever you are highly physiologically aroused, it is very difficult to pay attention or focus, which also leads to difficulty in sleeping. So, this hyper arousal is also another thing that happens. One of the core symptoms, at least two of these symptoms is commonly found among PTSD or the people experiencing PTSD. Criterion F, which is required, it says the symptoms last for more than 1 month. So, because that is the difference between acute stress disorder and PTSD. If it is less than 1 month, then it can be called as acute stress disorder, but if it is more than 1 month, only then we can call it as a post-traumatic stress disorder diagnosis. Criterion G, which is also required, which says symptoms create distress or functional impairment. So, this is also very important. Whenever we say something is disorder, the idea is that it is kind of influencing negatively your functioning also. So, your day to day functionings, your occupational functioning, your social functionings are impaired, you are not able to perform them properly. So, that functional impairment is also one of the important criteria to be called it as a disorder. Criterion H, which is also required, which says symptoms are not due to any other factors related to, such as medication, substance use or other illnesses. So, some of these symptoms can be associated with some medication, some substance use or other illnesses. If it is not associated with the traumatic event, then we cannot call it as PTSD. So, these are important criteria that are proposed by DSM-5 based on all the recent research findings to diagnose somebody as with PTSD. So, typically if you see there are 4 clusters of symptoms in PTSD, which are very important. Very briefly, one is re-experiencing, of the traumatic events. Avoidance of trauma related stimuli, hyperarousal in terms of physiological arousal, and fourth one, which was introduced in DSM-5, is negative thoughts and emotions. So, these are the 4 clusters of symptoms, and within each cluster there are specific categories that we have discussed. So, these are very important criteria in terms of PTSD, and these are many people may experience these symptoms after traumatic event, and it is very common, but one may not be really or experience disorder. For disorder we need all these specific criterias, and it has to be persistent and functional impairment, so many things. But these are common symptoms most of us will experience after a traumatic event, which may not become a disorder in many cases. So, this is in nutshell the symptoms of PTSD. So, the symptoms of PTSD are very common, as I have said. After the exposure to traumatic event, most of us will experience these symptoms. However, the majority of people do not develop clinical disorders. For clinical disorder, we need very specific diagnosis of each of these categories. So, according to American Psychiatric Association, website, they reported that approximately 3.5% of US adults experiences PTSD, and 1 in 11 people is likely to be diagnosed with PTSD in their lifetime, and women are twice as likely men to have PTSD. So, this percentage seems to be double in case of women, that PTSD is more likely to happen in case of women as compared to men. PTSD can occur to people of any ethnicity, nationality, culture and age. So, it is a kind of universal thing. It can be experienced by people of any culture, any any nation, any age group. So, it is very common that many other conditions may co-occur with PTSD. So, it is very commonly reported, or research have indicated that many other comorbid disorders may happen or symptoms may happen with PTSD, such as depression, anxiety, substance abuse. So, these are very commonly co-occurring symptoms, they are comorbid symptoms. Now, PTSD can occur to children as well. So, we will look into little bit detail about the children aspect. So, it is not just that adults only experience PTSD. In some cases, PTSD symptoms may surface after many months or even years after the traumatic event. So, in some exceptional cases, it is possible that people are not immediately showing symptoms of PTSD, because people may become numb for some time, but they may express their symptoms even after months and years. So, it is possible that symptoms may be repressed initially, but it will be expressed later on. So, PTSD can be treated with psychotherapies and medication, and obviously, it is depending on the case to case basis. So, we will discuss in general about many strategies which are common to psychotherapies, and in terms of coping with the stress, sections of the chapters that we will be discussing in the upcoming lectures. So, some of these things we will also cover. In general, we will talk about in terms of how to cope with the stress and trauma. So, we will talk about little bit about PTSD in the children. Now, traumatic events may be encountered by anybody, including children. So, when children experience severe stress or trauma, they may many times develop long term symptoms which may persist for more than a month. So, many times they can be also diagnosed with PTSD. Studies indicate that children can develop PTSD after exposure to traumatic events such as violent crime, sexual abuse, natural disasters and war. So, these kinds of events, when children are exposed to such kind of events, or when they experience such kind of events, many children can develop PTSD. Now, diagnosis of PTSD in children is very complicated and very difficult, because for many reasons. So, some of these reasons we will discuss. So, it is very difficult and complicated. So, for example, this Kaminer and his colleagues 2005, in one of the research articles, they reported some of the reasons why it is so complicated. So, one reason is PTSD criteria requires most of the criteria that we have discussed. An adult can express it and say, this is what is happening with me, I am re-experiencing these symptoms, I have hyperarousals, or I get disturbed, I cannot concentrate, and all these symptoms can be verbally explained or reported by an adult about their internal states and experiences, but a children cannot express most of these experiences, because it is beyond their cognitive and linguistic skills in terms of explaining these inner states. So, this becomes very difficult, since they cannot report it. We need to kind of infer from their behavioral observations, or maybe by asking adults. which is kind of an indirect way of finding out symptoms. So, it is more complicated, so not so easy. Another reason is that traumatized children often display many other symptoms apart from the typical symptoms that are measured in standardized scales and instruments. So, for assessment of PTSD, many standardized scales and interview schedules are there, which typically looks into these symptoms that that I have discussed. But when it comes to the children, they may show many other additional symptoms which are not captured by these measurement instruments. For example, many additional symptoms may include the loss of recently acquired development skills. So, some children may show the symptoms in terms of reaction to traumatic event. They may kind of regress back in terms of certain acquired skills they have recently developed. They may suddenly no longer show those skills. For example, certain developments in the linguistic and verbal skills or language development that has happened, they suddenly kind of no longer speak that fluently, or they are not able to express something. So, those linguistic development that has happened, kind of they will regress back, or they were earlier very socializing with a lot of people, talking to a lot of people, now they are no longer talk to people. So, those kind of regression may happen in case of children. There is also possibility that onset of new fears or the reactivation of old ones. So, children may show certain new fears. For example, earlier children used to go out openly and play with other children. Now, he is no longer willing to go out and play with other children. So, he may develop such new fears. Children may also show accidents and reckless behavior after traumatic events. Children also show a lot of separation anxiety. So, they will cling to their parents, let us say, and they will not likely to go away from their parents, and those clinging behaviors may be very visible in children. Children also show many psychosomatic complaints such as stomach aches and headaches. So, all these symptoms are not typically captured by those standardized instruments which are primarily meant for adults. So, this makes it is more difficult to diagnose PTSD in children. And third reason is many young children may sometimes express post-traumatic anxiety that they experience after traumatic event through hyperactivity, distractibility and increased impulsivity. So, they become highly impulsive, hyperactive. So, many times those symptoms may be confused with attention deficit or hyperactivity disorder, which is another separate category, which may not be which may not have any connection with that traumatic event. So, it is possible sometimes one may get confused because of the some apparent similarity of symptoms with the hyperactivity disorder or attention deficit disorder. So, because of all these reasons it is more difficult and complex process to diagnose and kind of understand PTSD among children. But research shows many children and it is very much common among children also to develop PTSD after traumatic event. So, according to the Center for Disease Control and Prevention CDC website, there are many other general symptoms that children can display, such as reliving the event over and over in thought or in play, or while they draw something, they may relive those traumatic events. They express it in terms of their drawings, in terms of when they are playing. Nightmares and sleep problems are also visible among children. They also become very upset when something causes memories of the event. They also show lack of positive emotions. There may be intense ongoing fear or sadness. They may have trouble focusing or concentrating. They may be show also irritability and anger outburst. They may also constantly looking for possible threats, being easily startled, which is a symptom of hyperarousal. They may also act helpless, hopeless or withdrawn, not doing much activities. Sometimes they may deny that event has happened, or they feel numb, they may experience numbness. They may also avoid places or people associated with the event. So, all these diverse symptoms are possible. So, many of them are under those typical clusters of PTSD, but children may show beyond those symptoms also many additional symptoms. So, technically, we have discussed both acute stress disorder and post traumatic stress disorder. So, there is we have already discussed some of the differences. So, the difference typically lies in the fact that acute stress disorder occurs immediately after the trauma, and post traumatic stress disorder occurs as a long range effect of the trauma. So, it is more long term effect of the trauma. So, ASD and PTSD share many core symptoms, but ASD more prominently includes one particular symptom called dissociative symptoms, which is more pronounced in ASD, such as detachment, reduced awareness of the surroundings, derealization, depersonalization, and dissociative amnesia. So, these are mostly kind of one's experience discontinuity, or kind of scattered experience within oneself. So, one may feel dissociated from one's thought, memories, and the environments. So, this may be experienced in terms of these symptoms. So, this is more common in ASD. So, in a tabular form it is shown here. So, basically as we have seen, it occurs ASD is more it occurs immediately after the trauma. PTSD occurs as a long range effect of trauma, especially after 1 month. So, this onset of ASD occurs between 0 to 28 days after the trauma. So, it is generally within 28 days it kinds of gets resolved. Onset occur at least after 1 month of the trauma. So, it is after 1 month, if it is there, then it is PTSD. So, symptoms last between 3 days to 4 weeks, whereas in PTSD symptom last at least for 1 month and can persist even for several years. So, ASD share almost all the core symptoms of PTSD, but ASD includes dissociative symptoms, which is more pronounced, as I have just discussed, and PTSD includes primarily re-experiencing, avoidance, hyperarousal, negative cognitions, and ASD also includes most of these symptoms, but dissociation is more pronounced in ASD. Many people having ASD may develop PTSD if it persists. Now, along with the whole this literature of PTSD, there was another category of PTSD, which is one specific category of PTSD called as complex PTSD. The researchers have been talking about it as a kind of parallel category. This complex PTSD was originally formulated by one Harvard psychologist. Her name is Judith Herman in 1992 to describe a distinctive psychological response arising from events where individual is under sustained and coercive control of perpetrator, particularly torture victims, where a person is experiencing repeated and sustained traumas, and torture from some perpetrator. So, and Judith Herman kind of found that the normal PTSD diagnosis criteria is not good enough to understand such repeated and prolonged traumatic experiences. So, she kind of called it as a complex PTSD, and this complex PTSD was not actually included in the normal formal the DSM or diagnostic manuals of psychological disorders. So, it is still now not introduced in the DSM-5 also, but another parallel the diagnosis manual, which is called as International Classification of Disease, or ICD, the 11th division, 11th chapter, which was recently introduced. they included complex PTSD in their manual, and ICD is primarily managed by WHO or World Health Organization. So, complex PTSD was excluded from the DSM 5 or it was actually never introduced in the DSM classification, primarily because many researchers argued for that that the symptoms of complex PTSD can be accommodated within the framework of existing definition of PTSD. So, some people argued and there was some debate, because of that they could not introduce it, and they kind of expanded existing PTSD criteria using one more additional criteria which we have discussed, is called negative cognitions or negative thoughts and emotions. Still, obviously many people feel complex PTSD as a separate category is much more helpful in terms of understanding the complex traumatic events that some people experience. So, complex PTSD is considered to be especially likely to occur following exposure to repeated, prolonged and interpersonal traumatic events. So, it happens primarily not just on one single traumatic event. PTSD can happen after a single traumatic event, but complex PTSD happens mostly when it is repeated and prolonged. So, multiple traumatic events and it is repeated and prolonged. In those cases, people experience complex PTSD. So, the exposure to traumatic events could be over a period of months or even years, such as torture, prisoner of war situations, long term childhood sexual abuse, prolonged physical or emotional abuse, sex trafficking situations. So, where there is a prolonged and multiple traumatic events is experienced by the person, then it is no longer just PTSD, it is complex PTSD. Although most commonly seen in the wake of prolonged childhood abuse, this disorder can also occur in survivors of many other traumatic events such as torture. So, symptoms, it includes all the symptoms of PTSD, but it also includes symptoms beyond PTSD, because the experience of trauma is much more prolonged and it is multiple traumatic events. So, it includes additional symptoms include experience disturbances in self identity. So, this whole your sense of self identity kinds of get disturbed and shattered in the case of complex PTSD. There is an emotional dysregulation is very common, because when you go through such experiences, you are no longer able to you cross all the limits of tolerance and emotional regulation, ability to regulate your emotions. So, people show high emotional reactivity, violent outburst, these are very common in complex PTSD. And such people are generally also show that they find difficulty is in forming relationships. So, there is persistent difficulty in forming relationships, primarily because they are not able to trust people when such torture and such kind of abuses happens repeatedly and for prolonged time. So, they are not able to form relationships, very trusting relationships. Symptoms may also include periods of amnesia or dissociation. So, amnesia is more like you forget some part of the traumatic event. So, it is a natural mechanism or coping mechanism of our mind that we are, if you remember some events, it will be very disturbing and we will not be able to tolerate it. So, our mind unconsciously represses those or memories and we forget them. So, those kind of forgetting or amnesia or dissociation is also similar symptom, can happen in case of complex PTSD. It can also be expressed in terms of distorted perspective about the perpetrator. So, people are no longer able to perceive rightly who is what and what is right and what is kind of real behavior, and those kind of distortion of perception can happen. Feelings of guilt, shame, lack of self-worth, all these symptoms can be also be there with complex PTSD. So, so we have discussed in last 3-4 lectures about how stress is related to human health, and we have discussed both physical health and mental health, And in the physical health, we have discussed both infectious disease as well as non-infectious diseases, that stress can contribute to all kinds of physical diseases, and we have discussed in detail the mechanisms of how stress can cause all these diseases. And today we have seen that how stress can influence our mental health, particularly by promoting certain psychological disorders, and particularly ASD and PTSD, and it can really influence the quality of our life and functioning. So, it is very important to understand that stress can have all these diverse adverse impact in our health. So, with this I will stop today's lecture. Thank you.